Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. Today, we're looking at something that's pretty fundamental to making sure we do a good job with taking care of people in healthcare settings. How we understand when things don't go as planned, and how we learn from the vast majority of times when things work out just fine. The science of patient safety deals with preventing harm to people during healthcare delivery. So today we'll get under the hood of 3 philosophies in safety science: Safety 1, 2, and 3. We'll understand their core ideas, their assumptions about how the world works, and how these 3 views shape how we manage patient safety in healthcare settings on a day-to-day basis. Okay, let's begin with Safety 1. Its roots go way back to the early days of safety science. You see a problem, you fix it. Sounds straightforward, doesn't it? But it has some downsides, like hindsight bias. It's relatively easy to look back after something bad happens and think, oh, the cause was obvious. But the problem is you're only looking at the times things failed. But what about all the times things went right? Safety 1 tends to overlook them. It sees systems as decomposable and bimodal. Long words, so let's look them up. Decomposable means you can basically break the system down into separate parts or components. And the idea is if each part works correctly, then the whole system will work correctly. And bimodal means those parts are seen as working in only one of 2 ways, either correctly or incorrectly, on or off, right or wrong, like a light switch. Take the process of root cause analysis, for example. When something goes wrong in a healthcare setting, root cause analysis involves dissecting what happened to find that single faulty part. That could be a malfunctioning piece of equipment, or maybe a step a doctor or a nurse missed in a procedure. In Safety 1, there's the underlying assumption that healthcare systems are generally well designed. So when things go wrong, the tendency is to point toward human error. In many ways, yes, humans could mess up an otherwise safe system by not sticking to the plan. So you can see how that perspective would lead to efforts aimed at standardizing behavior, controlling what people do, trying to make everyone follow the exact same steps every time. That's Safety 1 in a nutshell. Find the failure, fix the failure, and try to standardize what humans do. Now let's shift gears to Safety 2. This perspective came about because systems are more complex than one human or one step. And given this complexity, the thing that should surprise us isn't that things sometimes go wrong in healthcare, but that they go right so often. Safety 2 moves the focus from failures to successes. It pushes us to look at all those everyday successes, our usual tasks, and ask, okay, how did we manage that? How did we get it right this time, despite all the complexity and all the potential pitfalls? So we try to learn from what works well, and then that becomes our baseline for understanding the occasional problem. Safety 2 sees complex healthcare systems as highly interdependent. You can't just break them down into parts because they're all constantly interacting and they're influencing each other in ways that are hard to predict. Think about baking a pie. You have your individual ingredients: flour, egg, sugar, salt, butter, filling. But when you combine them and roll them and shape them and bake them, you get a pie. This pie has properties, textures, and tastes that you couldn't predict just by looking at the flour alone. Safety in a complex system is a bit like that. It emerges from the interactions. But that doesn't mean that patient safety is as easy as pie. A hospital or a clinic isn't just a collection of doctors and nurses and machines. It's how they all work together, or sometimes don't. Take the example of a nurse giving a patient a medication in a hospital ward. To the untrained eye, it might look like 5 or so steps from start to finish. But in reality, when you closely observe the process, it has over 40 distinct steps. Are people still the weak link in Safety 2? Not at all. The perspective of Safety 2 is the flexibility of humans, our ability to adapt and adjust what we do to respond to the unexpected. That's actually what makes the system work. So we're the solution, not the problem. So basically, Safety 2 says we should be looking at how people navigate complexity in healthcare. It's not about analyzing every single success story, but selecting common tasks to understand normal functioning rather than just focusing on rare severe failures. Okay, so we've covered Safety 1 and Safety 2. Find and fix versus focusing on things going right. Now let's move on to Safety 3. It defines safety as freedom from unacceptable losses. Unacceptable losses. Okay. And who decides what's unacceptable? That's determined by people who have a stake in the system. It could be a hospital, clinic, patients, or people or groups that certify or regulate hospitals. And the goal in this view is to identify and reduce hazards. Hazards are conditions within the system that could lead to unacceptable losses. Think of icy roads as a hazard. The loss might be a car crash. The goal is to control the hazard, maybe by sprinkling salt on the roads or having flashing signs to warn drivers. The focus is still on preventing bad outcomes, but it seems broader than just fixing individual failures. It's about controlling the potential for harm. Safety 3 emphasizes that the healthcare system is more than just the sum of its parts. It focuses on the interaction between the parts, not just the parts themselves. Take our pie example. Even if I've added all the ingredients in my recipe correctly, my pie could still be inedible if the ingredients don't interact correctly with each other. For example, if the ovens that I bake my pies in have wide variations in the amount of heat they produce. In Safety 3, there's an emphasis on identifying hazards, potential conditions that could lead to problems. So we have these 3 distinct perspectives, and they each have value depending on the context. Our guest on today's episode of Mapping Healthcare is Dr. Carsten Engel. We talk about Denmark's National Patient Safety Adverse Event Reporting System and how we can apply some of these patient safety methods to help health systems improve care across a range of countries and settings. The views expressed on this show are mine and those of my guests. So Carsten, welcome to the show. You live and work in Denmark. To get us all on the same page, if you could give us a brief review of the healthcare system in Denmark, some basic information on how it's structured and financed, I think it'd be really helpful.
Yes. Well, healthcare in Denmark is mostly tax-financed. There is some out-of-pocket payment, mainly for medications, but there's a cap on the annual expense and, strangely enough, on dental care, which for some unknown reason is only to a small extent covered by public means. The hospitals are managed under 5 regions. They will soon merge to 4 regions, and we are a country of 6 million people. Each of these regions has 1 university hospital and a group of acute care hospitals. There's been a consolidation over the past 10, 15 years. So all of the hospitals are now quite large and have a broad range of specialties. Family practitioners, they run private businesses, but the access to them is free of charge, and they're paid by the regions. Home-based care is to a large extent within the municipalities, so that there are some problems with 3 disparate sectors, but there's a movement underway to organize them without bringing them under the same management, organizing them in clusters that have the total responsibility for care within a given geographical area. We have a small sector of private hospitals. They mainly do elective surgery, and they serve as a kind of overflow for the public system because we have a waiting time guarantee. And when the public hospitals can't live up to that guarantee, then the patient has the right to go to a private hospital, but paid by the public hospital.
So that's a great safety net you have, where you have that guarantee of the private option on top of the public option. Seems like that's comprehensive healthcare that people have really good access to. So I've known you, Carsten, for a few years through the International Society for Quality in Healthcare, or ISQA. You have a medical degree from the University of Copenhagen, and you're an anesthesiologist by background. And the University of Copenhagen is famous for a lot of things. One of its claims to fame is that it's where Niels Bohr, who received Denmark's first Nobel Prize, created the atomic model that formed the basis of quantum mechanics and our understanding of how the world is built. So, really illustrious people from there. And the university's other claim to fame is that it produced an ISQA CEO, and that is you, of course. So, tell us briefly about your journey from becoming a medical doctor to becoming ISQA CEO.
Well, I worked for almost 20 years with clinical work or with management in the hospital sectors. I was quite early interested and attracted to leadership roles. I was head of a department. I became medical director for a smaller hospital. But as things happened, there was a restructuring and there was no need for so many medical directors. So I was asked, what do you think about being a clinical quality director for our county? And I said, well, I can give it a try. And in that role, I was responsible for implementing the adverse event reporting system in our county. Denmark was at that time organized in 14 counties, not 5 regions. And I also was to some extent involved in the collection of numeric quality indicators, which is a big thing in Denmark. And eventually accreditation was introduced to Denmark, and I thought it might be interesting to work with that. So I got a position with the Danish Institute for Quality and Accreditation in Healthcare, and I was there for close to 15 years. And during that time, I learned about ISQA, and I've been associated with ISQA for a very long time. I've been to every ISQA conference except one since 2005. As a deputy chief executive of the Danish Accreditation Agency, I represented us on ISQA's Accreditation Council, and I became a surveyor for the International Accreditation Program, and it was a great experience to come around the world and see how accreditation is performed in other countries. And eventually, when there was an open position, I applied for it and I got it, and I haven't regretted for one day that I joined ISQA. It has been a great time.
And you've had a long and illustrious career with ISQA, and you brought to it not just your background in patient safety incident reporting, but also your background in accreditation and medical practice. And so, for our listeners who may not be that familiar with accreditation in healthcare, it's essentially a process where external trained peer reviewers evaluate a healthcare organization's adherence to standards, and that helps keep patients safe and helps make sure that these organizations adhere to standards that deliver high quality care. So, talking about patient incident reporting systems, Denmark was the first country in the world to introduce a national mandatory patient safety incident reporting system, and that was over 20 years ago, back in 2004. And it's a really well respected system. And through this method, health professionals and pharmacies and patients, even in Denmark, confidentially report patient safety adverse events to a government owned database. And the goal of these reports is to learn from them and to prevent similar events from occurring in the future. And when physicians or nurses or pharmacies report, my understanding is that this reporting does not result in any disciplinary actions against the reporters purely for learning. And today, many other European countries have databases like Denmark's, and the World Health Organization as well recommends such a system to prevent patient harm in healthcare. And I read that the system in Denmark is restructured now and is going to be run at the regional level, but still remains a valuable way to keep people safe from healthcare related harm in your country. So, this has been decades of work in patient safety in Denmark that's been going on. So, Carsten, what would you say are the top successes that healthcare systems in Denmark have had in the past decade or so in improving patient safety?
Well, obviously, the incident report system is one of those successes. I believe that there has been some realization that the collecting of this information in a big national database did not have quite the impact that you had hoped for. Of course, there are some errors, mainly errors of a technical type. If there's something wrong with a device, for instance, that's a very good thing. But when it comes to more complex chains of event, the situation is different and it's not always feasible to identify and then eliminate one core root cause as we thought at some time. But I have no doubt that there's been a lot of local learning from the adverse event system, and first and foremost, perhaps that it has initiated a huge change of culture. The second success, I would say, is the way in which the COVID pandemic was managed. Denmark came out with one of the lowest, not the very lowest, but one of the lowest excess mortalities in the world, and our healthcare system was never really driven to the edge, as we saw in some of the countries where the pandemic began. And the third thing I would mention is our clinical registries. We have a very intense collection of data, mostly data related to treatment of specific diseases. There is this saying that 60-30-10, 60% of care is in accordance with evidence-based care, 30% is of small or no value, and 10% is directly harmful. You would say that we are focused very much on bringing up the 60 now, because what we monitor is the implementation of evidence-based clinical guidelines. There are successes in that, and it has also led to a centralization of some kinds of treatment with a measurable impact. But this being said, it is hard to measure patient safety, as you know. So establishing a strict chain of evidence that this intervention had this impact is difficult. But in some other areas, you can also, based on this data, see a clear improvement. For instance, we have a good database where data on hospital-acquired infections are tracked. And for many years, it was kind of depressing to look at it. But now you can see that in particular, urinary tract infections, which is the most common hospital-acquired infection, is clearly going down. And this may be tracked back to some efforts that have been taken to target good care for especially patients with a bladder catheter.
So that's lots of improvement, lots of change that has been occurring in Denmark because of all its patient safety interventions and improvements in safety culture. Incident reporting systems fall under the domain of what's called Safety One in healthcare, identifying what went wrong and using that information to prevent future issues. But things go right in healthcare most of the time. So, a complementary but different approach is Safety Two, where we figure out what went right with the goal of creating more resilient health systems. So, clearly, using a combination of Safety One and Safety Two approaches means a shift in perspective on how our hospitals and our health systems look at patient safety. In your mind, what are some of the challenges in implementing a Safety Two approach in healthcare settings?
One of the pioneers within Safety Two, Erik Holnagel, he didn't only work in Denmark, but he was a Dane. And I think the theory of Safety Two has a great face appeal. The problem is to translate it into something actionable. One of the challenges seems to be that we are almost designed to think linearly in terms of causes and effects. And what I think is fascinating about complex system is that there's no mystique in it. There are clearly definable cause and effects all the time. But when they combine in a network with things happening from the outside affecting the system, then the system in actual practice becomes unpredictable. And that can be hard to grasp, I think. But also, it seems much more simple to find and fix than to learn to manage. But that's what we need to find ways to support.
Yeah, and both of these approaches are challenging to measure as well as study in a systematic fashion. So, with Safety One, we've had that issue around how exactly do you define errors and, are these valid definitions? And with Safety Two as well, there have been challenges around trying to study this in a way that's evidence-based. So lots of work to be done for patient safety researchers clearly in these domains.
And we shouldn't forget that many processes in the healthcare systems are actually linear. It makes good sense to make a linear analysis of how you, for instance, initiate a blood transfusion. There are some definite steps, and there's a right way of doing things. The challenge is that when things come together in unexpected ways, then errors emerge. Actually, one of the first encounters with the patient safety thinking was a video on a vincristine accident where a patient erroneously was injected with vincristine instead of methotrexate intraspinally, which is lethal. And when you reflect back on it, you will see that a lot of things happened. And none of them happened because people were careless. They happened because they were accommodating to patients' wishes and preferences, because emergency came up and you tried to compensate for them. And yet everything converged to a disastrous result.
A large part of our attention in healthcare over the last 5 years has been on managing and containing the COVID-19 pandemic and its aftermath. And a lot of healthcare innovations have been developed or scaled up in these past 5 years, spurred by the pandemic. So, looking ahead now, what are some healthcare innovations in the next 5 years that you're looking forward to that are likely to improve patient safety?
The obviously one to mention would be artificial intelligence. We hear a lot about artificial intelligence. It may, to a certain extent, be a little bit hyped at the moment, but I'm totally convinced that it will make a huge difference, both in the way we manage individual patients, but also in the way we manage systems. We will be able to collect and analyze data to understand how the systems work, maybe testing out in a simulatory setting what the consequences of changing something in the system will be, which is not always easy. And the cooperation between AI and humans has a great potential. And I know that every time a new IT system has been introduced, we have expected that now things will become easier. And people do not always feel it that way, though I guess if they were moved backwards in time to the time before they got, for instance, the electronic patient records, they would not be entirely happy with what they experienced at that time. But it should relieve healthcare professionals of some of the tedious clerical work.
Artificial intelligence based tools are really changing some of the ways we practice in healthcare and some of our patient safety interventions. For our listeners that might be interested, episode 3 of Mapping Healthcare focused on artificial intelligence in healthcare. That conversation was with Dr. David Bates in Boston. So check that out. And Carsten, your tenure as ISQUA's CEO will be coming to a close in May 2026 with your retirement. You've kept the organization stable and growing through lots of challenges in the world, including a pandemic. And during your time leading the organization, which of ISQUA's accomplishments during your tenure are you most proud of?
Well, first, I'm proud that we can say that ISQUA is in a good condition. And this, of course, not just due to me, it's due to the staff, it's due to the board, it's due to the network we're working with. But then one of the things that we have changed quite dramatically is the way our education offerings are structured. We now have a fellowship which offers a possibility for online learning. We are building some communities of practice, including one in North America, another one in Africa, that are also going very well. And it is now in a way that is scalable. We can grow this education offering to a much larger scale. And then accreditation, it has been one of the core business lines of ISQUA for almost ISQUA's entire existence. And it is time to take a step back and see what accreditation should look like in the future. We have initiated a strategic process to map that and have that discussion. Next couple of years, I'm sure that we will see a market change in the way in which accreditation is performed. Again, AI can do a lot. We hear that in education, you have experimentations with systems through the Internet of Things, compile micro-credentials, and that could be one interesting way to explore for accreditation. Why do you have a survey, then you are accredited for 4 years, and then you have the same survey once again? Why not say, when you are accredited once, you remain accredited as long as you meet the requirements, and maybe modern technology can give us a way to collect that and initiate improvements if needed on a continuous basis.
ISQUA has gone really far under your leadership, and there's so much more exciting work to be done. And you're right, the world of healthcare accreditation is rapidly evolving, and there are many organizations looking at this concept in a different way going forward. As we wrap up this conversation, let's talk about something not related to healthcare. So, in addition to your passion for quality and safety in healthcare, you're interested in history and literature. And one place these two areas intersect in Denmark is at Helsinger, also known as Elsinore. This is a town outside Copenhagen that has the 15th century Kronborg Castle, which is the setting for Shakespeare's Hamlet. So now that you're looking forward to retirement and maybe having a little more time on your hands, I thought this would be a good question for you to ponder. What are some other places or experiences in Denmark that a new visitor to the area should check out or not miss?
Well, First, there are a lot of things to see in Copenhagen, but you should also consider coming to Aarhus, the second largest city of Denmark. It's in Jutland. It's 2.5 hours from Copenhagen. There we have what's called the Old Town. It's a museum where they collect town buildings from all over the countries, and they're arranged so that you have buildings from the late 16th century, and then you have scenic areas where you move along a timeline. And what's very interesting to me is there's also a section devoted to the early 70s, which was when I grew up. And well, it's already in the museum, and it's very interesting to go and see how they have collected entire interiors of apartments and living places, so we can really see how people lived and worked in those days. Now they also are beginning to establish a section for, I think, around 2005 or something, so the future will also be able to see how we lived. That's an interesting place to go.
That sounds fascinating. It also makes me a little bit sad to think that the period that I grew up in, which is like the late 70s and the 80s, is probably going to end up in a museum soon. So that makes me feel kind of old. But that being said, that seems like a really fascinating place to explore. So with that, I just wanted to say thank you so much for being on Mapping Healthcare. I really value the time you spent with us today, and really also value the time that I've got to spend with you and learn from you through our mutual connection with the International Society for Quality in Healthcare, or ISQA.
Thank you. And it goes both ways, of course. I also enjoyed it.
So that was Dr. Carsten Engel telling us about Denmark's National Patient Safety Incident Reporting System that's been around for over 2 decades. It helps health professionals in Denmark confidentially report patient safety adverse events to help their and other organizations learn from these issues and prevent similar problems from occurring in the future. And we also heard about 3 distinct perspectives in patient safety. Safety 1, find and fix failures. Safety 2, understand how things go right. And Safety 3, control hazards in a system. And combining these 3 approaches helps us make healthcare settings resilient enough to respond to unexpected problems. None of these approaches are as easy as pie or even a Danish pastry to implement. But all 3 of them are still critical to a well-rounded healthcare buffet, or for our friends in Denmark, to a well-rounded healthcare cold pour. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM, where we explore healthcare around the world, highlight people who improve it, and share what we can learn from them. If you enjoyed the show, please subscribe and leave a review. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts.